Hey everyone, have you ever wondered how certain medications help treat conditions like glaucoma, altitude sickness, or even epilepsy? Today we're diving into the world of carbonic anhydrase inhibitors. But before we talk about the magic of these drugs, we need to understand how our kidneys function. Let's get started. Understanding kidney functions and urine formation. The kidneys are like the body's filtration system. They perform three main tasks to keep us healthy. 1. Balancing the body's chemistry. The kidneys regulate important electrolytes in water. Think of them as the body's natural chemists. 2. Removing waste. Our bodies create waste from metabolism, and the kidneys ensure these waste products are flushed out through urine. 3. Producing hormones. Did you know your kidneys make hormones? They produce erythropoietin, which stimulates red blood cell production, and renin, which helps control blood pressure. Now let's follow the journey of how urine is made. Step 1. Filtration. The blood passes through the glomerulus, a network of tiny capillaries that filter out water and small molecules while keeping large proteins and cells in the bloodstream. Step 2. Reabsorption. Important substances like glucose and sodium are reabsorbed back into the blood to prevent excessive loss. Step 3. Secretion. The kidney actively removes extra waste and acid to keep the body's pH balanced. The nephron, the kidney's filtration unit. Now let's zoom in on the nephron, the functional unit of the kidney. Imagine it as a long, winding highway where essential substances are either reabsorbed back into the bloodstream or excreted as urine. 1. Glomerular filtration. Blood enters the glomerulus. Here, small molecules pass through, while larger proteins and blood cells remain in circulation. 2. Proximal tubule. This is where most sodium and bicarbonate are reabsorbed. Passive chloride and water reabsorption, organic acids and drug molecules are actively secreted here. 3. Loop of Henle. This is the nephron's magic trick. In the descending limb, water moves out, making the filtrate more concentrated. In the ascending limb, sodium, potassium, and chloride are pumped out, making the filtrate more dilute. The vasa recta maintains an osmotic gradient by absorbing sodium chloride from ascending limb and water from descending limb. How carbonic anhydrase inhibitors work. Now let's discuss the superheroes of today's topic, carbonic anhydrase inhibitors. These drugs work by blocking the enzyme carbonic anhydrase, which plays a key role in reabsorbing bicarbonate and sodium in the kidney. Normally, carbonic anhydrase helps convert carbon dioxide into bicarbonate and hydrogen ions. When carbonic anhydrase inhibitors block this process, sodium and bicarbonate stay in the tubule instead of being absorbed, causing more water to follow, leading to increased urine production, a process called diuresis. However, because the kidney compensates downstream, carbonic anhydrase inhibitors aren't as strong as other diuretics that act later in the nephron and are used mainly in glaucoma. Understanding the structure-activity relationship of carbonic anhydrase inhibitors. Carbonic anhydrases are ubiquitous metalloenzymes that efficiently catalyze the reversible hydration of carbon dioxide to bicarbonate. In humans, all carbonic anhydrases contain a zinc ion at the active site, coordinated by 3 histidine residues and a water molecule or hydroxide ion. There are 16 isoforms from the carbonic anhydrase enzyme. These isoforms differ in molecular features, cellular localization, distribution in organs and tissues, expression levels, and response to various inhibitors. Carbonic anhydrase inhibitors contain a sulfonamide group, acts as a zinc-binding motif. It coordinates with the zinc ion in the active site of carbonic anhydrase via its deprotonated nitrogen, inhibiting the enzyme's ability to catalyze carbon dioxide hydration. Different types of sulfonamides. Primary, the most effective for zinc binding. Secondary, substituting one hydrogen with small alkyl or aryl groups or electron withdrawing groups lowers pKa, enhancing acidity and zinc binding. Bulky groups may reduce binding via steric hindrance. Tertiary, usually inactive due to poor binding ability. Other features that influence carbonic anhydrase inhibitors. Effectiveness. Heterocyclic rings helps in binding to hydrophobic pockets near the carbonic anhydrase active site. Rigid rings orient the sulfonamide group for optimal zinc coordination. Bulky groups. Enhance selectivity for different carbonic anhydrase isoforms, allowing for targeted treatments. Therapeutic applications of carbonic anhydrase inhibitors. Now let's see how carbonic anhydrase inhibitors are used in medicine. 1. Glaucoma. They reduce the production of aqueous humor in the eye, lowering intraocular pressure. 2. Idiopathic intracranial hypertension. Decreases cerebrospinal fluid pressure, relieving symptoms like headaches. 3. Altitude sickness. Helps the body adapt by correcting respiratory alkalosis. 4th, congestive heart failure. Acts as a mild diuretic to remove excess fluid. Metabolic alkalosis. Helps correct excessive blood alkalinity by promoting bicarbonate excretion. Urinary alkalization. Used to prevent kidney stones by increasing bicarbonate excretion, which solubilizes uric acid and cysteine stones. Common carbonic anhydrase inhibitors and their uses. Acetazolamide, Cytomax. Acetazolamide is a thiodiazole derivative, was the first of the carbonic acid anhydrase inhibitors to be introduced as an orally effective diuretic with a therapeutic effect that lasts approximately 8 to 12 hours. It is used for glaucoma, altitude sickness, epilepsy, diuresis, and metabolic alkalosis. Side effects include hypersensitivity reactions, nephrolithiasis, and metabolic acidosis. Methazolamide, Neptazane. Methazolamide is a structure analog of acetazolamide in which one of the active hydrogens in the thiodiazole ring has been replaced by a methyl group. This decreases the polarity of the compound and permits greater penetration into the ocular fluid, reducing the intraocular pressure. Has a longer duration of action than acetazolamide used in open-angle glaucoma. It has less risk of metabolic acidosis than acetazolamide. It has lower renal excretion because it is more lipophilic, allowing better tissue penetration and less renal clearance, so it lowers the risk of nephrolithiasis. Dichlorphenamide, Keveyis. Dichloro substitution in benzene ring increases lipophilicity, which leads to a longer duration of action. It is FDA approved for treating hypokalemic and hyperkalemic periodic paralysis. Primary periodic paralysis is rare, a genetic disorder that causes recurrent episodes of muscle weakness or paralysis due to fluctuations in blood potassium levels. Dichlorphenamide helps regulate potassium levels and reduces the frequency and severity of paralysis episodes. It has less risk of nephrolithiasis and drowsiness than acetazolamide. Brinzolamide and dorzolamide, azopt and trusopt. Brinzolamide and dorzolamide contain ionizable amino groups and are the result of efforts to develop water-soluble carbonic anhydrase inhibitors that retain sufficient lipophilicity to penetrate the cornea. They are only indicated for topical eye administration in glaucoma patients. However, both drugs can be absorbed from ocular fluids into the blood. This results in prolonged half-lives. They may cause temporary blurry vision and ocular irritation. Other therapeutic applications: sulcium, ospalat. Sulfonamide fused into a phenothiazine ring, pre-organized zinc binding. Approved in several European countries, e.g. Germany, UK, as monotherapy or adjunctive therapy for focal, partial seizures, particularly in children. The phenothiazine ring's size and hydrophobicity favor interactions with brain-specific carbonic anhydrase isoforms. Unlike acetazolamide, sulcium's structure minimizes off-target effects on renal carbonic anhydrase. Quiz time. Now that you've learned all about carbonic anhydrase inhibitors, it's time for a quick quiz. Pause the video to think before the answers are revealed. Question 1. What is the most critical structural feature for the activity of carbonic anhydrase inhibitors? A. Presence of a sulfonamide group. B. Presence of a hydroxyl group. C. Large hydrophobic moiety. D. Ester functional group. The correct answer is A. Presence of a sulfonamide group. Question 2. What is the primary clinical use of carbonic anhydrase inhibitors? A. Treatment of hypertension. B. Management of glaucoma. C. Relief of edema in heart failure. D. Control of diabetes mellitus. The correct answer is B. Management of glaucoma. CAIs reduce intraocular pressure by decreasing aqueous humor production. Conclusion. And that wraps up today's exploration of carbonic anhydrase inhibitors. These drugs have a wide range of applications, and research is uncovering even more potential uses. If you enjoyed this video, don't forget to like and subscribe for more deep dives into pharmaceutical sciences. See you next time. Thank you for watching.